This video is a presentation of the Tennessee chapter of the American Academy of Pediatrics. Funding is provided by the Tennessee Department of Education, specifically the Tennessee Early Intervention System TEIS, and the Tennessee Department of Health.
Hello, I'm Dr. Deanna Bell, President of the Tennessee chapter of the American Academy of Pediatrics. I want to welcome you to the Screening Tools and Referral Training Program, otherwise known as START. The science behind the screening is one of 6 videos that make up a 2.5-hour physician-led, office-centered training program to help us all improve the care of children with developmental, emotional, and behavioral disorders. Let's find out more about what we can do to be more effective in primary care. Dr. Quentin Humberg, a developmental pediatrician and the medical director for the START program, tells us how to get started.
Welcome to Module 1, the Science of Developmental and Behavioral Screening. Let's think about what you do every day in practice in a well examination. As you can see from the chart, 2/3 to 3/4 of children that you're going to see every day are going to be healthy and normal, and your job is to basically tell the parents that the child is doing well and that they're doing well as parents, as long as giving them some good anticipatory guidance and preventive advice. Some children have concerns, as you know, and those are those kids that are easily identified in your practice. 2 to 4% have obvious severe disabilities, such as cerebral palsy or other physical or motor disabilities, or even genetic disorders. About 1 in 7 have a special health care need, such as diabetes, congenital heart disease, or epilepsy. These kids are not hard for you to detect, and your pediatric training provides you that basic information. The difficulty is illustrated in the green portion of the pie chart. 20 to 30% of kids have an undetected developmental, behavioral, personal, social, or learning concern. These are what we call the oh by the way kinds of problems, because when they walk in your office, there's not an obvious concern. But the parents often know that their children have some concerns, and we need to find a way to identify these children as early as possible. You might ask yourself how many kids you're actually screening in your office in your program. When we look at national surveys, the data shows that we could do better. Tennessee in the latest rankings was ranked 23rd in the country, showing that about 28% of children in the last year had received a validated screening tool in the first 6 years of life that discussed that child's concerns for developmental, behavioral, or learning concerns. That seems pretty poor, but when you look at the best state in the country was Oregon, only 49% of children were receiving a screening tool. The bad news is we're not screening very many kids in Tennessee. The good news is there's a lot of room for improvement here, and with training programs such as this, we hope to improve the rate of screening throughout the state. The science tells us now that about 1 in 4 visits that come into your office are going to have some sort of developmental or behavioral concern. They have done studies that have actually shown that this is a significant burden of time in the average pediatrician or primary care provider's office. Visit time goes up more than 5 minutes every time those kinds of concerns are raised in the office. This should be of no surprise to you. The other very important point is that if we ask the right question of parents, 4 times out of 5, they're going to give us the right answers, and that's going to lead to better identification and earlier services for kids. The AAP agreed with this now over 10 years ago with a policy that was just reaffirmed in 2016. This policy from the Council of Children on Disabilities recommends that all practices do routine surveillance and standardized developmental behavioral screening for children with concerns. So let's talk about the difference between surveillance versus screening. We, in practice, have for many years done developmental surveillance. A common quote was from Dr. Paul Dworkin, listed on the screen here. It's a continuous or flexible process in which you, as a knowledgeable professional, can see the child over time, oftentimes beginning at birth or even prenatally, and make skilled observations and examinations of that child and the child's family. This process works very nicely when you can do that. Unfortunately, we find that in many practices, we do not see children on a continuous basis, and we try to use surveillance, but surveillance cannot pick up things when you don't see the child. The 5 components of surveillance as defined by the EPSDT, Early Periodic Screening, Diagnosis, and Treatment requirements, are listed here. We should document this in each child's chart as part of a well child examination, and that should include taking a good history, maintaining a developmental history of the child, listing risk and protective factors, make informed observations of the child during your visit, and document the process and findings. These are likely being done in your office visits now, but this is not the same as screening. Screening would be adding one important component, and that would be a validated test that's going to help you determine whether or not this child is either okay or needs further investigation. Screening tools are never going to help us make a diagnosis directly from a screening tool. They're only going to guide us in the direction of gathering more information. The science points out from the policy statement mentioned before that we should perform this based upon our clinical judgment, but at minimum, all children at 9 months, 18, and 30 months should get a developmental screening tool. In addition, we should do autism screening for all children at 18 and 24 months. These are not the only times, however, that you should do screening. Screening should be done at any time a concern arises, either from you as the provider or from the parents. This slide really illustrates visually what we've just been talking about, which is that developmental surveillance happens across the age span, and the pictures will illustrate a typical 9-month-old, 18-month-old, and 30-month-old. However, like a lot of things in your medical practice, even if you have no concerns and the parents have no concerns, we should screen all patients at 9 months, all at 18 months, and all at 30 months. For autism, there should be an additional screening at 18 and 24 months. We need to be objective. Just like your thermometer or your blood pressure cuff in your office, you're much better off getting objective information than you are trying to touch the child on the head when they have a fever and determine what you're going to do. So, in an optimal setting like we described, primary care providers are very good at detecting problems. But screening is going to complement that because we're not always able to get good continuous surveillance of our patients and families. And as we showed, the screening rates in Tennessee and other states can certainly be improved. This is the one slide that really is the sell point for the entire science of screening tools. The question is, which column do you want to be in? If you look in the without screening column, you'll find that many studies have shown that detecting developmental delays or behavioral concerns is significantly lower in practices that do not use screening tools. In other words, if you follow the screening tool protocols that we're going to describe to you, we can just make you smarter. So it works. We've proven this through the science, and it results in kids getting services sooner. It's clearly going to, I'll show you soon, that it's going to be cost effective, and it improves the satisfaction of both the patients and the families that you serve. One reason why we're very excited about doing screening tools is the fact that we can save a lot of money in addition to helping the children. We find that 50% of all children that have special needs are not detected until kindergarten or later if they are taken care of in practices that have not been screening. The educational system tells us this results in a huge increase in cost for services for special education, speech therapy, and other related services. For our early intervention program, Birth to 3 TEIS, data shows that we save anywhere from $3 to $17 per child when they're identified in a medical practice or through other means. That turns out to be nearly $100,000 returned per child. That actually covers a lot of potential services for children and improves the outcome for all of us. And finally, patient and family satisfaction is significantly improved. We all want to engage our families more effectively in terms of helping them with their child's development and helping them be more active partners. Screening does just that, and we'll show you with some of the sample tools how we can engage parents more and get them more invested in their child's health care. The final requirements are listed here. Our current TennCare EPSDT screening guidelines require screening in accordance with Academy guidelines or when there are specific concerns. There is not a limitation on the amount of screening that you're able to do in your practice currently. The Individuals with Disabilities Education Act, IDEA, also, as part of their child find requirements, recommends screening. And I mentioned the guidelines for health supervision from the Academy of Pediatrics. Our Tennessee Department of Health has updated protocols that you should discuss with your supervisor for the latest information on your screening protocols. Get the right start. If you don't screen, you're going to miss potential problem children that could be made significantly better with early referral and treatment. Let's discuss some of the barriers that may be apparent to you in your practice. The 4 things listed here are things that we hear over and over again whenever you change anything in your practice setting. Time, knowledge of how to do the tool or methods of how to do it, familiarities with how you're going to document that, are you going to get paid, and then what about follow-up procedures. And then when we screen, we have to have some place to refer children with concerns. We'll discuss each of these in the subsequent modules, and particularly in detail about our youngest children birth to 3 with TEIS. The challenge you're going to really find is not so much implementing screening, but with yourself in terms of deciding that this is the right thing to do. I'm hoping that the science that we presented will help you move forward and understand that this is something you can do and it is beneficial. All providers have difficulties making changes, and you will probably not be any different. We want to avoid the 3 most dangerous words related to this presentation, which is let's wait and see. As a developmental specialist, I heard these words over and over again on referrals from primary care providers when the families indicated that their primary care person had told them, let's just wait and see. Screening allows you to move forward with the family right from the first concern and not get trapped into that pattern. We also want to not rely just upon your observations. We've shown that in a brief 13 to 17 minute well examination period, it's very difficult for the most experienced primary care providers to detect problems that parents would be seeing at home. So the summary is we want to do developmental screening, and the science supports that. It's not the same as what practices are doing through surveillance. It is beneficial to our children and to our practices, and you'll find it very rewarding to implement. Let's get the right start. Some additional resources about screening are currently available through the American Academy of Pediatrics. The Screening Technical Assistance and Resource Center, STAR website, provides a lot of background information that will complement what you're learning today. START, a journey of 1,000 miles begins with a single step. More information is available at our website, www.tnaap.org.
This has been a very informative presentation for me, and I hope it has been for you as well. Thank you for joining us.